Hello, everyone. It's Larry Kotlikoff. I'm here to interview Amy Finkelstein, who has just written a fantastic book with a co-author, Liran Einav. If I'm pronouncing Liran's, that's the name of the book. It's called We've Got You Covered, Rebooting American Healthcare. So I've written or read a lot about healthcare and written a bit myself. And I have to say, having spent the last 6 hours reading this book quickly, but I think thoroughly, it's a real terrific contribution to the analysis of healthcare. It's kind of encyclopedic in terms of its analysis of studies of healthcare, but it's also a complete page turner. It's just a delight. Every sentence is beautiful, but every sentence compels you to go to the next sentence. It's very much at the level of just the average person in the street who knows nothing about healthcare. If you know nothing whatsoever, it's probably a good thing, because whatever you know is probably gotten you focused in the wrong direction. But this is a comprehensive look at why our healthcare system is so incredibly screwed up, the different ways, and also how to fix it. So let me just briefly introduce Amy's background. She's one of the top economists in the entire universe. Let's just start there. She's a professor of economics at MIT. She's the co-director and research associate of the public economics program at the National Bureau of Economic Research. She's co-scientific director of JPAL North America. In 2012, Amy received the John Bates Clark Medal for her contributions to economics. So this is like the Nobel Prize for young economists. This is an award given, I think it's every 2 years, to the top economists under 40. Am I correct on that, Amy? Is it every 2 years or every 1 year?
I think it's every year now.
Every year now, okay. She's a member of the National Academy of Sciences. It's not at all an easy thing to become elected to. And she won a MacArthur Genius Fellowship in 2018. We're going back 5 years. So Amy's as close to a genius in economics as we've got, at least on this podcast at this moment. And but she's also a lovely person and completely down to earth, and that comes through. And I'm sure your co-author, I don't know, Liran. This is just an every person's read, and you learn so much so quickly. And it also has a prescription for how to fix the healthcare system, which is kind of very different from what other people may be prescribing, what I've thought about. So we want to talk about this. But Amy, let's start this discussion off by describing how you kind of where you're born and how you decided to get into economics. Let me just briefly mention that you have a undergraduate degree in economics at Harvard, where you were
Uh,
trained.
Actually, in government or political science,
Government.
which is part
Oh,
of. So it took me a while to get to economics.
okay. So went to government, and you were a Truman Scholar. You graduated summa cum laude in 1995. So we're talking of a few years ago. Harvard. She was inspired by Larry Katz's work and course about the social problems in the American economy. She was a Marshall Scholar at Oxford, where she got a MPhil, which I guess is a Master's of Philosophy in Economics. So she studied at Oxford for 2 years. Then she went to get a PhD in economics at MIT, where she studied under Jim Viterbo and Jonathan Gruber. Jonathan was very much involved in the Affordable Care Act as, I guess, the architect, really. And then Amy served for 3 years as a junior fellow at the Harvard Society of Fellows. This is like basically the the brightest of the bright young academics, scholars are brought together in the Society of Fellows and have 3 years just to think and do research. And then she joined MIT's faculty in 2005 and started writing, very highly prolific, and ends up getting, just 7 years later, gets the John Bates Clark Medal. This is as good as it gets in economics. Amy, tell us where you were born and how you got into economics a little bit.
Yeah, and also thank you, Larry, for that extremely, perhaps overly generous introduction. I do have to at least partially return the compliment. You mentioned you've been interested in healthcare for a while. You've also written a terrific book on healthcare, which we read as part of the work we were doing for this book, and I continue to think it's the best title ever, The Healthcare Fix, and
Yeah.
I wish you'd simply not used it and told me about it, and we would have used it. But anyway, to answer your question, so I was born in New York City, and grew up in Manhattan in the 70s and 80s, at a time in which some people now refer to it as a time in which no one in their right mind would raise children in Manhattan, but there we were. And actually, both my parents are academics, but they're biologists. And I always loved school. I think I knew certainly by the time I got to college that I was really wanted to be an academic, both because I love school and I like research papers, and also because I don't think I'm constitutionally suited to anything in the real world. But at the same time, I always liked science, but I was never particularly drawn to further study in science or in biology. In fact, my great love in high school was history, and I still love history and I love reading history. Um, but I decided I didn't want to major in history or potentially do a PhD in history because I thought, perhaps mistakenly, I've never really gone back and revisited it, that, then I'd sort of just learn more and more about less and less. Whereas I got, and so I got excited and drawn to political science in part because it seemed like a way of using history to sort of build models of the world. And I remember reading Barrington Moore's Social Origins of Democracy and Dictatorship as a freshman and just being floored, like, wow, somebody could take this, mastery of knowledge of history across time and across space and use it to build theories and models for the world. The problem was I didn't have that mastery of history. And I realized it would take a long time to actually accumulate that, and I was a little impatient. And also at the same time, I'd occasionally show one of my political science term papers to my father, who's a biologist, and he would read and say, "Okay, that's like a nice argument, but you could have just as equally made the opposite argument." Like and he was sort of right, at least at the term paper level that I was working on in college. And so that drew me to empirical political science, which was sort of starting then, particularly in American political science, to try and use data and statistical modeling to understand why certain laws got enacted, or why certain funding was allocated. And I really liked the methods, but sort of and I ended up writing my thesis on something related to that. But by the end of my junior year, I was sort of, realizing I wasn't that interested in why a law was passed as much as I was interested in like what the effect of that law was, or what law should be passed. And so really, and you mentioned this already, this sort of eye-opening or life-changing moment for me came in the fall of my senior year when I took an undergraduate economics course that Larry Katz was teaching called I think, oh God, the social problems in American policy, I think was the name of it. And what was stunning to me is that, it was covering many of the topics that, as a, college student in the early 90s, I would sit around and debate with my, friends in late night college bowl sessions. Does welfare encourage dependency? What's the effect of, having no fault divorce insurance? And what was stunning about this course was to realize that, these weren't questions that had to be settled by just rhetoric and, who had the, cleverest argument or one-liner in our college bull session, but that you could actually bring data and evidence and rigor to
Right.
bear on trying to answer these questions. And so at that point I was completely hooked.
So when you went to Oxford, you studied economics at Oxford
Yeah,
for?
I mean, I was hooked, but I was woefully unprepared at that point to do a PhD in economics. I had taken, undergrad. I'd taken the Ec 10 course, and I'd taken intermediate micro and macro, and I'd taken Larry's course, but I really hadn't, I mean, and I'd taken a bit of math just because I'd always liked math, but I'd sort of never, I hadn't done what students do now when they're preparing for grad school. And so I was very fortunate to get a fellowship to study for 2 years at Oxford and to do the master's, which in some sense is the first 2 years of a PhD program, but at least the way they did it at Oxford at the time, there was no exam till the end of the first year, whereas at MIT, where I subsequently went for grad school and I now teach, we do 6 weeks of consumer and producer theory and then an exam, 6 weeks of game theory and then an exam, and that would have been a disaster for me because I got there and realized, coming from political science, there was a lot of background I just didn't have, and I was very fortunate that with this system where you don't really have to master anything till the end of the year. I had a lot of, and the sort of 8 weeks on, 6 weeks off nature of the Oxford trimester system. I had a lot of time to just, go and fill in all the missing pieces so that by the end of the year, I actually knew some economics.
That's a really cool story for people, especially younger people, watch this podcast because I've had about 40 people on the podcast since I started maybe a year and a bit ago. And I just thought it'd be fun to start talking to people about their work and their careers, uh, and in addition to kind of writing newsletters for my Substack site, I had the Ribitzer brothers, Jim and Bob Ribitzer, on a couple
Oh
weeks
yeah,
ago.
I'm
This is
partway
their
through
book.
their new book. Yeah, yeah,
Yeah,
yeah.
and their angle about healthcare is much more about, and they loved your book, and it sounds like you probably love theirs. They're two great books. They're two brand new books about healthcare reform, and they're focused much more on technology and innovation that can reduce our costs from what appear to be 18-17% of GDP down to the at least 12%, which was at the high end of all the other countries, advanced countries. And I think that you said in your book that the typical or the median or the average is somewhere around 9% of GDP. If you look at Sweden, for example, they're spending, I think, 11% of GDP on healthcare. They have the fourth best ranking. We're spending 18%. We've got the 21st best ranking. We have a problem. And we're also leaving all those bills for our kids, in addition to all the Social Security unfunded liabilities. So we've got a fiscal disaster connected to our healthcare system, as well as a delivery system disaster. And you're focused on something that you haven't really, at least you say in your preface, the two of you felt compelled by, I think, your father-in-law
Oh,
to actually not just write about what's wrong and and how people are reacting to the current laws, but also how to reformulate the healthcare system. What would you do if you were the healthcare czar and you had basically free hand over fixing the healthcare system? What would you put in place? That was your father-in-law's challenge, and you took it up, and you've written this book that's only 198 pages. It's extremely readable. I'm telling you, this is so much fun to read. You
thank you
can't.
so much. We that was our goal. There was this aha moment when we realized that unlike our academic papers, which we can assign to our students and they have to read them, no one actually has to read our book. So it was on us to make it not only substantively, hopefully interesting and important, but actually fun to read. And those are my favorite kinds of books to read by
But
academics in other fields who've
yeah, but
done that.
the thing that makes it so readable is there's so many real world stories about individuals who, I remember this, there's one place here to talk about a guy, a burn victim. He got burned in some kind of an accident. He goes to the hospital. I think they put an IV bag on, and then they kick him out because he doesn't have the health insurance coverage. And he spends about 7 hours driving around to different hospitals, third degree burns,
with the IV bag still
with the
attached.
IV
Yeah.
bag until he finally gets admitted. I mean, but there's one story after another like this, and it's not just stories about what's going on in America. This is a wonderful analysis of what's going on with respect to healthcare provision in other countries that are doing it very differently, and some are succeeding in doing it differently, and some are failing or succeeding in certain ways and failing in other ways. But you have the Einav and Finkelstein solution, which is what we really need to get into. So why don't we have you start out by telling us about the book from your perspective, and then I took some notes, so I'll pepper you with some questions, but maybe kind of give us a tour of your book, and then kind of get to the big punchline about how you think about the fundamentals of how the whole thing needs to be restructured and not piecemeal. Piecemeal has been the problem as you push it, as you say, and I think most people in health economics agree. So you have a let's start from scratch approach here. Guys, take it away, Amy.
Thanks. I think I'd say the place we start is, I think, both kind of obvious and natural to us from our training as economists, but I think is not where most people start, which is before we start debating or proposing solutions, we have to define the goal, the objective, what it is we're trying to accomplish. Because I think it kind of boggles our minds that a lot of debates in health policy, and perhaps more broadly, start arguing about the merits of A versus B without ever articulating what it is we're trying to accomplish. And so what we argue is the need for health policy reform, which, there are many possible reasons for it, but what we see from looking both at our current practices on the ground, as well as the history, going back to my interest in history, the history of social policy in the United States for decades, if not centuries. And this is something you write about, I was gratified to see in your book as well, so I knew we weren't just totally making it up, is there's this clear, we call it an empirical social contract, if you will, as a society, that we are committed to providing or trying to provide access to essential medical care, even for people who lack the resources to afford them. And that may be a sort of bizarre sounding statement to make, given that we are, as most people know, the only high income country that hasn't enacted universal coverage. We're also a society that, famously has a frontier individualism, pull oneself up by one's bootstrap type of ideology. But as we argue, hopefully convincingly in the book, all that notwithstanding, when you look at the policies that have been enacted, they are clearly this response to we refuse to at least consciously and openly stand idly by while people are critically ill and could be dramatically helped by technology that's available that they can't afford. And so we go through that argument in some detail in the book, but I don't think at some level, I haven't yet heard anyone who's willing to stand up and say, no, that isn't our social contract.
This is basically, let me just say it in slightly different words. We have health, and well, you actually say it exactly in these words. We have universal health insurance in our country. We just don't have it being provided efficiently or rationally. We're putting people at enormous risk in the process of providing universal health insurance. It's not uniform, it's not equal, it's equitable, but we have it because we don't let somebody walk around with third degree burns for more than, let's say, 7 hours in the car. Ultimately, they get to a hospital and it will take them in. So that's the sense in which we have.
Yeah, or as we found from the Oregon health insurance experiment, which was a something the state of Oregon did where they had limited funding to allocate public health insurance, Medicaid, to low-income uninsured adults, and they decided to do it by lottery. And Kate Baker, who's now was an economist at Harvard at the time, now provost at the University of Chicago, and I led a multi-year large team study to use this randomized trial of allocating Medicaid to some low-income uninsured adults and not others to say what are the effects of Medicaid. And yes, formal health insurance has real benefits to people compared to being uninsured. Better financial security and protection against large out-of-pocket medical expenses or medical debt, increased use of healthcare, and improved health by some measures. But yet, if you just turn it around and say, okay, but what is it like to be uninsured compared to being insured, as opposed to what are the benefits of being insured? What we find is that the low-income uninsured are still receiving about 4/5 the medical care that we estimate that they would receive if they're insured. And that includes not just emergency care in the hospital, but primary care, preventive care, physician visits. And here's the really important part, they only pay about 20 cents of the dollar they only pay about 20 cents on the dollar for that care. And other studies have similarly looked at the amount of health care that uninsured individuals get and find that they're spending only about 20 to 30 cents on the dollar. So that's the point in which you say no one is literally uninsured in the United States for their health care. What would it mean to be literally uninsured? It would mean that they would receive no medical care unless they pay for it. So we don't have that. On the other hand, as we also talk in the book, many of the currently insured are not in fact well insured. So we kind of have a universal mess, on both ends.
So we have insurance that kind of universal insurance that puts everybody at risk. Let me give you just one anecdote that I was on a podium. I gave a talk together with Sandra Day O'Connor in 2006. This was like a month after she had stepped down from being Supreme Court Justice. And she, I guess the conference was about health insurance and coverage. And it was the Peterson Foundation down in Washington. And I'm wondering, why is Sandra Day O'Connor speaking about health insurance? And she gets up and she starts asking the question, why is it that the richest country in the world, not sure we're the richest, and well, there's different measures, but can't provide basic health insurance to everybody in the country. And she was pushing this and saying how important it was. So afterwards in the break, I went up to her and introduced myself and said, let me guess, you have somebody in your family who doesn't have formal coverage. She said, you're right. It's my son. Well, actually, it's my grandson. My son's insurance policy doesn't cover my grandson, his son, who's got a significant health problem. And I said, that means you're uninsured in the sense that you're at risk. Again, just that child is getting, in the end of the day, will get some help, healthcare help, and but it may end up bankrupting her son, but ultimately bankrupting the former chief, justice of the Supreme Court, because she's ultimately on the line to take care of her grandchild. So we are all insured, but we're also all uninsured, even if we think we've got a solid policy. If our kid, our cousin, our brother doesn't have coverage, or the nephew, we're on the line. So what we're doing is it's kind of a patchwork insurance, and that's one of your chapters is about kind of here it is, now it's here and now it's gone, health insurance. So take us through the beginning of the book, and then we'll get into the grand solution here.
Right. So I think the other key point we make early in the book, in addition to this argument about this, social contract that we've talked about, is that while policy and academic attention tends to focus, and it's understandable, on the 30 million Americans who lack health insurance at a point in time, or lack formal health insurance, as we've just described, actually, if that were the only problem, then perhaps an incremental reform, another patch or two, if you were, could potentially be all that we need. Unfortunately, the problems with insurance coverage or health insurance coverage in the US are much deeper, and they extend to the 90% of Americans who are fortunate enough to have health insurance at any given moment. And there are two main problems. One is, which we find very perverse, is that health insurance, whose very purpose is to provide some modicum of economic or financial security in the event of poor health and high medical bills, is itself highly uncertain. So, while the statistic we often hear is that, about 10% of Americans under 65 lack health insurance at any moment, and that number was, almost halved by the Affordable Care Act in 2010, a much higher number of Americans under 65, in fact, more than twice that number, 1 in 4 Americans will spend some period of time over a 2-year period without health insurance. In other, so both
one in four. Let me just emphasize. You're saying one in four of people listening to this podcast or throughout the country over the next 2 years are going to be uninsured for some period of the next 2 years.
If they're under 65, yeah.
They're under 65. So that says it all. I mean, another way to think about this, I would say, would be assume that we had full coverage for everybody, but we also had a government program that randomly hits you with some major bill unexpectedly over the next 2 years, or so, it just kind of a full insurance plus a policy of randomly financially destroying your life. That may be a different way of wrapping our heads around what we've got. And we want to get rid of the second part.
And I think there's two important sort of subpoints of that. One is that it's not like, oh, you'll be uninsured for a few days or weeks while you're changing from one plan to another, which would itself be, undesirable and risky. But when people lose insurance coverage, I think something like, over half of them are still uninsured, 2 years later, and, so maybe over a quarter of them are uninsured 2 years later. So there's a risk of being uninsured for a long period of time. And the second is, this is not a problem that's limited to one particular group of the insured, that it includes people who have employer provided health insurance, as well as people who have public Medicaid coverage for low-income individuals, or have purchased health insurance through the health insurance exchanges. So yeah, it's a really big problem. Just
to tell us on the employer, because most people listening to this probably have pretty good employer-based health insurance. Tell us about the folks who end up even with that coverage getting into big problems, because you do have one example, and then go on to what you were about to say. Don't forget.
I will forget, but I'm sorry, I don't recall what example you particularly have in mind.
I think you talked about somebody ended up with a 40 that pretty much everybody, well, maybe it's not everybody, but at least 1 in 3 the employer-based plans have significant out-of-pocket deductibles.
So that was
right.
That was the second point I was getting to, which is it's not just that everyone risks losing their coverage, everyone under 65, but everyone who's insured, including the over 65 as well, perversely risk paying potentially very high out-of-pocket expenses or incurring medical debt for their so-called covered care. Excuse me.
Sure.
And so when it comes to private insurance, private employer-provided insurance, a lot of this reflects the increasing trend towards high deductible health insurance, where you have to pay the first $2,000, $3,000, $4,000 out of pocket yourself, as well as an increasing move towards higher coinsurance that can be a lot higher, 2-3 times as high if you go out of network. both of which can leave insured individuals with enormous expenses. And then for the public program like Medicare, it's by design. There's a 20% coinsurance for any physician visits that's uncapped, so that you can have unlimited medical expenses if you're unfortunate enough to have, a serious illness that requires a lot of physician expenses, such as, cancer treatment. And so, again, this is not how insurance is supposed to function. The purpose of insurance is to protect us financially, particularly against catastrophic expenses. And, one of the statistics I think we give in the book is that not only is there an enormous amount of unpaid medical debt in the United States, it's more than the amount of consumer debt held by collection agencies for all other non-medical sources combined. But, and
It's
this is the
$140
really,
billion.
yeah, $140 billion. But the really shocking part to us is that 3/5 of that debt is incurred by households that have health insurance. So this is not health insurance functioning as it's supposed to.
So Bernie Care, Senator Sanders' proposal to extend traditional Medicare to all, is a proposal to leave everybody in the country potentially dramatically underinsured because exposed to risk, because traditional Medicare is not full coverage. And it's not full coverage exactly where you need it when things are most expensive and you have to pay 20% of your recurring out-of-pocket, out-of-hospital visits. And then I think there's a cap on lifetime Medicare. Is that
hospital? Yeah, I think there's a lifetime cap on like extra hospital days in Medicare. But yes, this is just not how it's kind of backwards from how a sensible health insurance plan should be designed.
So we have, and the other interesting thing is you are an historian, because you go back in time and you talk about Alexander Hamilton having instituted the first universal health insurance, or at least it was health insurance for seamen, right?
Yeah, it's the first national compulsory tax financed health insurance. So it wasn't universal, but it was for all commercial sailors. And this is one of my favorite discoveries in working on the book, because I have yet to come across any other economist who had any inkling of this fact. In fact, as a separate matter, it didn't make it into the book because it was a little off topic, but I went and read the sort of congressional record and the committee reports on this bill, and the debates and the pros and the cons bear a eerie resemblance to what happened over 200 years later in the debates over the Affordable Care Act.
So it's so funny, yeah, that the history just kind of repeats it.
Yeah, except the Act for the Relief of Sick and Disabled Seamen took up a page, whereas I believe the Affordable Care Act was something like 1,600 pages. But they're very similar. Both compulsory health insurance, tax fine, deducted from people's sailors' wages when they return to port, 20 cents per month per sailor at sea. And then it was supposed to be collected by the sea captain and handed over to the customs agent and used to finance care locally, for the very reason that, as we've talked about, inevitably when people can't afford medical care and are ill, somebody picks up the tab. And in this case, it was the local communities where the sailors, were returning to port ill, far from home. And like the Affordable Care Act, there was also a fine on the employer, in this case it was on the employer, not on the individual, but a fine on the captain if he didn't in fact collect and hand over the payroll tax to pay for this compulsory health insurance. The fine lasted a little longer than the one in the Affordable Care Act. I think it managed to survive for about 75 years.
So we're going to turn to your proposal, your broad scope of your proposal, but I just wanted to reinforce this issue of health insurance. I was giving, just with another anecdote, I was giving a talk over at the Brookline Club. I think it's called the Country Club. or the club, I forget what it's called, but it's the oldest country club in the country. It's very exclusive, but somehow they let me in the door to give a talk. And I gave a talk about, when I wrote my book, The Healthcare Fix, I was giving a talk about it. And as soon as I started talking, a couple guys jumped up literally out of their seats and started screaming at me. And this is a very august, setting. You may have been there once or whatever, maybe you belong, but they're screaming at me, why should I be paying for somebody else's health insurance? Why should we, everybody should be paying for themselves, and we should not have government involvement, should be completely private. And then I asked them, when they calmed down, I said, let's calm down. I asked them what their profession was. Both were doctors. And so this is a very conservative group, very Republican, if you like, in terms of their libertarian really outlook. And then I asked them, each of them, do you know anybody with health insurance, without health coverage, health insurance? And they both sheepishly said yes. And then I said, let me guess, is one of them a relative? And they both said yes. And I said, are you on the line for taking care of that relative? They both said yes, and then they sat down. So we have, but again, that relative would they don't realize that this is really them not being uninsured when we don't have universal, but they also didn't get this point that we have had since, as you say, back at the beginning of the country's founding, this basic fundamental social contract that we're not going to let somebody, drive around for months with 3-degree burns. We're just not, that's not our social mentality. So that we have health insurance, universal health insurance, we just have the worst version perhaps of it, because it's so random, and you can be dumped from one hospital to another, and you can fall through a crack and lose your life's, your future standard of living just because of one couple of weeks of not being covered by accident, that you're switching from one system to another. Anyway, tell us about we've got you covered, Rebooting American Healthcare. Yours are for as long as it takes, so the healthcare system. What are you going to do? What's your basic solution here?
So it turns out once you clarify and hopefully agree on the purpose, the solution we think is very simple and straightforward. If we agree that we're inevitably always going to come to the aid of people who are ill and unable to afford essential medical care, then the solution, and this is what I want to emphasize, that has been actually, it's not new to us, and it's also been embraced by people across the political spectrum, is to recognize that we're going to inevitably do this, and therefore formalize that commitment and fund it upfront. So, our proposal is twofold. First, universal automatic basic coverage, and then the option for individuals who want and are able to pay for more than the basic to buy supplemental coverage in a well-designed and well-functioning market. So that's it. So it can't quite fit on a bumper sticker, but I guess it's pretty close. Somebody wrote to us after they read our book and said we should have called it freemium plan, which is apparently a term, for in various businesses, that you get some basic thing for free and then you pay a premium if you want more. So that's another.
You described this in part, in one place you described this as kind of analogous to Medicaid for all plus Medicare for all. The Medicaid for all being the basic coverage, basic needs coverage, and the Medicaid being the supplemental.
I'd say the basic.
Medicare.
I'd say the basic is, in many ways, you can think of as broadly very similar to Medicaid for all, in the sense of it's completely free to the patient with both no premiums, but also no copays, deductibles, and cost sharing. It would, if it was for all, be universal and automatic. The fact that it's not for Medicaid is part of the problem with the Medicaid system, that people are constantly either not realizing they are eligible for coverage, or failing to enroll, or failing to stay enroll. And like Medicaid, there would be wait times that are longer than what people with private insurance tend to experience. Not longer than what Congress has decided is acceptable for veterans covered by the Veterans Administration health insurance program, but longer than private insurance. And, some limits on, choice of doctor or the various, what's known as gatekeeping for, maybe you have to go see a primary care physician to get referred to a specialist or get prior authorization for a particular medical test. It would be better than Medicaid in two important respects. First, you wouldn't have that insurance uncertainty, that risk that you might lose it. And second, by law, you're not allowed to supplement Medicaid. If you want something that's a little better or more generous than Medicaid, you have to completely give up your tax financed Medicaid coverage and purchase a private insurance policy that in which you're paying for not only the additional things you wanted, but you're repaying for all of what you would have gotten under Medicaid.
Plus, we have this horrendous distortion of labor supply choices, because if you earn too much money, you lose your Medicaid for yourself and your kids, which can be astronomical taxation. So we're kind of locking the poor. This and many other programs collectively are putting roughly 15% or so of the poor in marginal tax rates brackets above 70%, which is kind of a finding of a recent study, co-authored study I did. And then we've got a lot of, a huge chunk of people over 50% marginal tax rates, poor people. So what you're suggesting, which is universal basic insurance with no payment, but also, no loss of it if you earn more money, no tax associated with it, would dramatically change work incentives, and that could get people unlocked from poverty into working and contributing, paying taxes to help finance this, because you're using, I think you have in mind using general revenues to pay for the system. But if we let's recall, we're paying 18% of GDP on healthcare. If we could get down to around 12%, we don't know is needed that much in the way of taxes that we currently.
Yeah, we actually we come at the sort of what would it mean for taxes angle a little differently, which is to say, if although it is true both that the US spends a much higher share of its economy on healthcare than other countries, and a much greater share of that is privately financed, it's still the case that if you add up the taxpayer spending on Medicare, on Medicaid, on the tax exclusion for employer-provided health insurance, that you get to about 9% of GDP. So about half of US healthcare is already publicly financed. In other countries, the average in the OECD is that total healthcare spending as a share of GDP is about 9% of the economy, but most of that is publicly financed. So in other words, if you just take what other countries are spending out of taxpayer dollars on their universal basic coverage systems, that's very similar to or sometimes even lower than what the US is already spending on taxpayer dollars for our non-universal coverage system. So it's possible we might decide we want a more generous basic system and we would raise taxes, but our point is we don't have to necessarily increase taxes to get automatic universal basic coverage. We just need to take the current tax dollars that we're spending in a sort of suboptimal or inefficient way on a combination of Medicare, Medicaid, and the employer tax subsidy, and use it instead to fund this automatic universal basic coverage.
In some ways, we could just kind of swap out. Maybe this is not going to be exactly your system or proposal, but swap out the U.S. system for the Swedish system, go from 18% down to 11%, and almost all of that we already have the tax revenues to do, and we don't. And they're giving it healthcare for free basically at the margin. I don't know what their copay story is, but
very low, very low.
Very low, yeah. So you view the basic care component of your proposal similar to the National Health Service of England and the Canadian Health Service, which are kind of basic government provided healthcare Uh, but then you talk about supplemental coverage. You reference Singapore, Israel, and Switzerland as having the best models of supplemental care. So talk to us a bit about the integration of, one of the things you emphasize when you talk about the supplemental component, which is going to be a big part of this plan, is that it shouldn't be, this or that. It shouldn't be you go from basic healthcare and if you want to have a switch, have better services and pay premium for that commodity, which is buying insurance. So you're taking, at least maybe have a private room, your whatever it is you want to buy with your supplemental premium dollars. It shouldn't be that you lose the basic health care, or that part of the problem is that if we go in that direction, which I think some countries have, especially in poor countries, we have a two-tiered system where politically there's much less support for the basic healthcare program that's supporting, the poor left behind. Whereas if you have everybody together, so how would you integrate supplemental care and basic care as are?
Yeah. So as you said, we do it the way many countries do it, in which what, and in fact, perhaps the easiest way to explain it is we do it the way the current Medicare system allows for supplemental coverage. So there's the traditional Medicare program for physician and hospital insurance, in which there's a, automatic, universal, if you're over 65, coverage of physician and hospital visits, but it's provided by the public system. But about 40% of individuals who are eligible for that instead choose to purchase private insurance known as Medicare Advantage. And effectively, the way it works is private insurance has to cover the same basic benefits that the public Medicare program covers, but then they sometimes offer supplemental benefits such as coverage of your cost sharing, and they impose some restrictions to try and make the financing and profits work on their end, like limits on the choice of doctor you can see, you have to go in network, or prior authorization. But the way you pay for it is if someone wants to get private Medicare, they effectively get a voucher from the government equal to the cost of what the government estimates they would have spent on this individual in the public Medicare program, and they use that towards paying for their private Medicare plan. So they don't have to repurchase what they would have gotten from the taxpayer financed Medicare plan if they want to go to the private sector.
So
And
this is
that's one way of thinking about how our proposal would work.
So that sounds like your proposals feels very similar to my proposal and many other health economists. Victor Fuchs, your co-author's colleague at Stanford, who's kind of the dean of health economists. I think his view is also. So I think that there's a consensus, because not being a health economist myself, when I set out to write my book, The Healthcare Fix, I've been kind of like this boy economist walking around and figuring out, hey, we got a problem here. Let's write a book about it. Or let's figure out what to do to fix it. But then I would go talk to other economists before I started off, so I wouldn't make a complete fool of myself on the topic. So this idea of basically Medicare Part C, or Medicare Advantage for all, is what I wanted to kind of conclude our discussion around, whether that's really your model, as well as Victor's, as well as mine, as well as and other people who have looked at this.
So I mean, at some broad level, and I remember when I read your book and also Zeke Emanuel and Vic Fuchs's work, there's a lot of commonality. I would say that, we're not quite Medicare for all in two respects. Medicare for all, including the ability to go to Medicare Advantage as part of that. One is we think that the current Medicare program would have to be redesigned to cover all the cost sharing, right? So that you wouldn't have this unlimited 20% of all physician pays have to be paid out of pocket. On the other hand, it's not all, rainbows and unicorns. We're not just saying more, more, more. The basic coverage would be a lot more basic than what people currently get under the Medicare program. So for example, right, sorry, go ahead.
I was just going to interject that, just to be clear, I was proposing, and I'm still proposing, we get rid of traditional Medicare. We just have Medicare Advantage for all. So it's not like you can, because there you can have, people can game the system, and healthcare providers can game it. I'll take care of you until you get really sick, and then I'll send you to the traditional Medicare where you have, go see anybody you like.
Yeah. So we have no strong view in our book. And one thing we talk about is part of what made us feel we could make some progress is that by identifying, the goal, you can then separate what is essential, that there has to be universal automatic basic coverage that doesn't have cost sharing with the ability to supplement, and what is important, but reasonable people can disagree on, and there are trade-offs on, such as whether this automatic universal basic coverage should be provided by a single public insurer, the way it is in the UK and Canada, whether it should be provided only by private insurers, which is, I think, what you're proposing with Medicare Advantage for all. That's what Switzerland and the Netherlands currently do, or whether you should have, the so-called public option and a mix of both a public and a private insurer, which is what the current Medicare system does. It's what the Australian system does. And there are real costs and benefits to each of them. And our view is, maybe that's the subject for another book, but our point is you can achieve the essential elements of universal basic automatic coverage through any of those. So if you're someone who's wedded to, we don't want any public insurer, we want only private, look to your Medicare Advantage for all plan, or the Netherlands or Switzerland. If you're someone who wants both, look to Australia.
Yeah. Okay. I agree that there's, lots of kind of titles of plans that we could have things that sound different, but are fundamentally identical. And where I'm coming from is this point of competition, that people have the ability to walk with their feet from one, in effect, HMO, from one Kaiser Permanente to another, if they don't feel, and that would keep, but my view is everything would be paid for by the government. We would get down, the competition would lower the 18% down to 12.9, maybe 9, and we can have a much more efficient tax system because of this, and the competition would get the quality of the care up to the Swedish level, at least, because why not? I mean, but we'd also want to have the providers provide things, they couldn't say, okay, we're going to provide this but not that, and they couldn't say we're going to operate in this part of Dallas but not in that part of Dallas, which is what's happened with Obamacare, that you have a lot of providers initially came in to provide affordable care plans, but then they pulled out, and so I think there's just 2 hospitals that take affordable care plans now in Dallas, in the worst part of the lowest income part of the city, and it's not accessible to many low income people because of the distance. So there's going to be a need for another book from you two. Okay, your father-in-law is not going to be entirely happy. Okay, he's going to be happier. He's going to say you did a fantastic job, but when it comes to whatever Thanksgiving dinner, he's going to press you on the more of the details. Okay, we've got, and so I in particular am looking forward to that, to the next book. This is going to be book number 2 for you, right?
Yes.
Okay, I'm on to book number 21. I'm a little bit older. You have time. Keep at it, because you guys are really fantastic authors. I mean, you can write about a whole lot of things. In addition to, you could look, economic history is also something maybe in your future, given what you've done here. But, this is a fabulous, again, everybody should go get this. When did this come out, Amy?
It just came out at the end of July, so it's
Okay.
brand new.
Has it gotten much attention nationally?
I think so. I mean, it's always hard to tell, but yeah, I've been gratified to see, a lot of interest, as I said, across the political spectrum and from a lot of different types of outlets. So that's been terrific.
Yeah, the thing about, this sounds like a policy book, but it's more like a let's look at what the hell we're doing book. Let's look at what's going on. Let's really understand what's going on here and abroad. Let's get a handle on this very complicated thing. So this is a reality check in many ways book. So everybody listening to this podcast, I really heartily recommend you take a look, because it will change if you're far to the left, far to the right. What Amy and Liran are saying is, it doesn't matter. Get the politics out of this. It's not get the politics out of this. Get to reality, which is that we're not letting anybody walk, in the street with a broken arm, at least for too many hours. We're going to get them to some care. And now that now that we have to realize that we are going to do X, and we've been doing X. And even if people don't like to say we're doing X or use those words, we are providing universal health insurance, but we have to realize that we're doing it in a terribly inefficient, inequitable, risky way. We're kind of insuring you with the left hand and then uninsuring you with the right hand. It's a mess. And Amy and Liran have got us very close to where we need to get through any solution. So I applaud you for this fantastic accomplishment. You're brilliant, and keep it up. Okay, keep pushing
Thanks so
hard
much, Larry.
on your
Really
work. Okay,
appreciate it.
thank you.